Thank you very much, and congratulations, Mike, for bringing this together. It's a wonderful thing. Today what I'd like to do is to focus on the major issues that affect mortality and morbidity here, but increasingly around the world, and to suggest from how we got here to where we perhaps need to go. And starting with cardiovascular disease, I'm going to suggest that the modern era really began with the identification of risk factors. Heart disease wasn't just something that happened when you got old. There were certain things that predicted it, and I'm going to give a lot of credit to the researchers in Framingham who set up shop in 1948 and discovered that smoking contributes to heart disease, and high blood pressure and lipids and overweight and so forth can predict this. And then, of course, the next question is, can these risk factors be modified? Or is high blood pressure something that you get just from being older? So many studies have done this. A classic example is the DASH trial, which showed that, yes, high blood pressure can be brought down, not with medications, but with rather simple diet changes and rather rapidly. And then the next question was, okay, can we go further and actually affect not risk factors, but endpoints? Like, do you die? Do you have a cardiovascular event? And a classic study in that, a classic example would be the Predimed trial, which despite it having certain issues, was a well-designed trial looking at what a Mediterranean diet can do, and in fact it can influence cardiovascular events. And some researchers have gotten more ambitious to try to see, can we actually reverse some of these pathologies in the body? And Dr. Dean Ornish's lifestyle heart trial or Dr. Esselstyn's studies have done exactly that, using a variety of lifestyle measures all together, showing that pathological processes can, to an extent, be reversed, and that over the long run, that too will dramatically influence the risk of events. So what we've come down to is that cardiovascular disease isn't from getting old. It has something to do with dyslipidemia, but there's a huge inflammatory component, and they do this ballet together that causes atherosclerotic changes and myocardial infarctions and stroke and other problems. And there are other contributors, but that's sort of the big picture. So when we think about where we go from here, I might surprise you by saying I think we need to look at children. And the reason I'm saying that is twofold. The first is that the behaviors that lead to this disease start in childhood. The 50-year-old man on the exam table who's had an MI in his heart is a 5-year-old kid who learned to like hot dogs. And if we are not intervening in children, our job is just dramatically more difficult, and yet we ignore all of that. In fact, we have this idea that kids are immortal and bulletproof, and we'll feed them anything, and then once they're demonstrating risk factors in midlife, then we're going to try to change. We need to research on how to change these things in children. But perhaps the more urgent and eye-catching part about this is that cardiovascular disease begins in childhood. Michael Skilton's work in Australia showed that obese mothers give birth to children who demonstrate aortic thickenings at birth. And a child of 16, 17 years of age, they've got the beginnings of atherosclerosis. They may have already lost one of their lumbar arteries because of the cardiovascular disease in the lumbar area. So we need to intervene in children. I think we also need to be aware that those people who are making products that elevate cholesterol and elevate blood pressure and do all kinds of things are getting smarter than ever, and they have active disinformation campaigns where they will publish articles in renowned journals trying to suggest that bacon is safe and steak is okay and so forth. And that is a bigger and bigger and bigger problem for not just the public and newspaper articles, but it's a problem for clinicians who start to think that science means nothing. I'll have more to say about that in a minute. Cancer, leading killer in much of the world. And again, the same process has gone forward where risk factors have been identified. The Nurses' Health Study and the other Harvard studies that have gone forward so elegantly, the EPIC trial. These have identified and helped us understand risk factors. I might also mention the Adventist Health studies, which I'll have more to say about. And they said they've been well summarized by the American Institute for Cancer Research and the World Cancer Research Fund and the World Health Organization. And where food seems to matter the most, not surprisingly, is where food goes, down the alimentary tract. So gastrointestinal cancers, particularly colorectal cancer, but frankly all the way from the esophagus down to the end. But also hormonal cancers, breast cancer, prostate cancer, but ovarian cancer, uterine cancer. Hormones are affected by food. Well, I'm going to give that its own chapter in just a second. But these are the areas where diet and lifestyle seem to make the biggest difference, and I am going to suggest that there might be less of a role for, say, blood cancers or neurological cancers or that kind of thing. That may not be the case, but that's the way it seems to be. So then the next question is, can I intervene in these risk factors? And the Women's Health Initiative, for all its flaws, was a well-designed trial of a rather weak intervention that did show that if you intervene with diet changes, you can move the needle at least a bit. You can prevent some breast cancers. And other studies have looked at post-diagnosis. Can a woman who has been diagnosed with breast cancer, can she be more likely to survive if she makes some diet and lifestyle changes? And the Women's Intervention Nutrition Study, the Women's Healthy Eating and Living Study both did that. And Dean Ornish's interesting trial published in 2005 looked at men with prostate cancer, showing that a low-fat vegan diet can dramatically change the course rather rapidly in men with diagnosed prostate cancer. So the research priorities I'm going to suggest are more prevention studies, more survival studies, and I think that we are in the face of, as was presented earlier, a certain amount of skepticism and a certain amount of just disinterest in looking at diet and lifestyle at the National Cancer Institute and other places. I think we've got to light a fire and say, we really, really do need to be doing more intervention trials and survival trials. Okay, with regard to type 2 diabetes, the epidemiology has been fascinating, and I want to give a lot of credit to the Adventist Health Study too, and Dr. Fraser, who is here and has done amazing work, showing just dramatic relationships with dietary patterns. And on this graphic, which I stole from Dr. Tonstad's work at the Adventist Health Study, showing that the red group, the daily meat eaters compared to the blue group, the vegans, you see this dramatic difference in type 2 diabetes prevalence. And the Nurses' Health Study has also shown similar relationships between dietary patterns and type 2 diabetes. And then our friends at Yale University and elsewhere have been putting patients in their MR scanners and showing through the pathology of this that you didn't get type 2 diabetes from eating bread. You got it from eating foods that packed lipid into the muscles and livers and liver cells that cause insulin resistance. And so if fat is building up in muscle and liver cells and insulin can no longer signal, then that shows us maybe what we ought to do to prevent it. Maybe it's more about the Velveeta than it is about rice. So our group and many others have been doing intervention trials, both to see if a diet change can improve diabetes or reverse it, and also if you stick then our patients into the MR scanner, do their muscle cells clean out? And indeed, they do. So where do we need to go? I think that we need to first do more translation studies. When I say translational studies, my laboratory in Washington is doing a certain amount of work, but if you're in Beijing or in frankly, or in Delhi or other areas, diabetes is an enormous issue that's not getting better, and there is, I think, a lot of just a loss of understanding of this. We need to also do translational studies in children, because type 2 diabetes used to mean you were 40 years old, now you can be 14. We also need to be looking at complications. Our team showed that you can intervene in people who have diabetic neuropathy. They've had the disease for a long time, their feet are killing them, and it's not too late to intervene with diet and lifestyle. But what about that person who's got eye involvement, or perhaps more than anything else, the person whose kidneys are teetering on the brink of extinction? If we could bring them back from dialysis, we would save a lot of money and a lot of heartache. So we need to be looking at both translation and complication prevention. Type 1 diabetes. Yes, there are genetic components to this, but there's a huge lifestyle or exposure component that needs to be better understood. Back in 1992, the New England Journal of Medicine had a fascinating article about dairy proteins triggering the production of antibodies that could potentially destroy the insulin-producing cells. We have not yet had good trials to really sort that out. The trigger study looked at this a little bit, but in my view, it was way too weak and flawed. But let's see if we can prevent type 1 diabetes by having children be breastfed, not allowing dairy protein exposure for as long as you can. And there are certainly other ways of intervening as well. But with regard to research priorities in type 1 diabetes, I think we need to look both at prevention but also at management. We have seen a striking number of people with type 1 diabetes using the diet designed for type 2, finding that despite increased carbohydrate intake, their insulin sensitivity improves and their insulin requirements go way, way down. And their endocrinologists get very nervous while the patient is getting healthier and healthier and healthier. We need to be investigating that. A frontier where there has been a lot of messy research, but tremendous promise, is in autoimmune conditions. And there's a whole lot of them. But what they have in common is that the body is attacking itself. And we have abundant case histories of the person whose rheumatoid arthritis went away, or Venus Williams' Sjogren's disease went into remission when she went vegan, and now she's got her game back. But we need trials. We need good randomized clinical trials in human beings that are adequately powered to see who benefits and what that benefit will be. So I'm going to suggest for autoimmune conditions we need large trials. Now, this is hard to do. We're doing a randomized trial now with RA patients, rheumatoid arthritis patients, of a dietary intervention. And the diagnostic criteria are really tough. And in the world of pharmaceuticals being marketed like crazy every 5 minutes on TV, it's very hard to find a virgin patient. They're all on drugs, and they all feel great as long as they take their Humira. But we really do need to have good randomized trials. With hormonal conditions, I hinted at this earlier, but what was identified in the 1990s for breast cancer patients, but forgotten in the 2000s, was that diet affects estrogen levels. A high-fat diet increases estrogen levels. A high-fiber diet reduces estrogen levels. And this was being teased apart in order to see if we could not only prevent breast cancer, but also slow progression. But the amazing thing is that biological change in a woman's body doesn't just lead to breast cancer, it leads to menstrual cramps and endometriosis and fibroids and adenomyosis and fertility problems, as well as the hormone-related cancers that crop up. Also in the hormonal area, we need to be looking at thyroid disease. Thyroid disease relates to iodine, of course, but that's not the reason why we have Hashimoto's thyroiditis in Pittsburgh. We've got it because of an autoimmune attack. And the same is true with Graves' disease and hyperthyroidism. And what is causing that? And we've seen lots and lots and lots of case studies where people alter their diet and their thyroid gets better. The literature on it is poor, however, and so we need good intervention trials to see what we can make of it. Okay, brain health. When I have made a list of all the diseases I want not to get, my number one is Alzheimer's disease. And observational studies have been really, really wonderful. And they have brought us tremendous insights that are now starting to lead to exciting clinical trials. And the Chicago Health and Aging Project under Martha Claire Morris and other trials at other centers have shown that, for example, when a person reduces or when a person is not consuming a lot of saturated fat in an observational trial, or has a lot of vegetables and fruits or a lot of vitamin E in their diet, they tend to have a reduced risk of getting Alzheimer's. And rather dramatically, reduced risk. In the Chicago Health and Aging Project study published in 2003, those people who had the least saturated fat in their diet had about 1/3 the risk of Alzheimer's disease compared to those having the most. So we're talking about a huge intervention. And then Dr. Morris is now pursuing the MIND trial, which is a big 3-year project using a weight-reducing diet. But Dean Ornish's team at the Preventive Medicine Research Institute is doing a fairly short-term trial, but perhaps more ambitious because it's in people with early-stage Alzheimer's, to see what diet and lifestyle can be. So we clearly need more trials. This is very difficult work, but we need to see what we can do. Now, the brain has other ways of going haywire, and mood disorders are among them. We have fascinating trials showing that mood is influenced by what we eat. And my own team did a study in 10 different cities at Geico headquarters, the car insurance company, where we instituted low-fat vegan diets to tackle diabetes and obesity at work. And it works great. But along the way, we looked at depression scores, anxiety scores, and job absenteeism. And the participants had no idea that we were looking at that. They just wanted to get skinnier. But what we discovered is that the dietary intervention measurably reduced depression and anxiety and so forth. Would it do the same for a clinically depressed person? Well, perhaps. There is a literature that suggests that it does, but we need good trials, solid trials, large trials. And they need to be carefully done because depression can be fatal. I don't need to tell you. Attention deficit disorder has been looked at ever since Ben Feingold wrote a book, Why Your Child is Hyperactive. And he said it's colors and it's flavorings and so forth and preservatives and salicylates. Maybe so. But other researchers have said, well, could it be sugar and caffeine and Red Bull? And could it be dairy proteins? We need more clinical trials. Something environmental is going on, and it's not all video games. It could be what kids are eating. Okay, so to summarize, the research priorities that I would suggest we might need, first should focus on causes as opposed to drug targets. Now, pharmaceuticals are wonderful, they are life-saving, and they're important. But they have risks, they have costs, and you take them forever. Because pharmaceutical companies have very little interest in an antibiotic that you're going to take for 10 days. They want you on Humira for life, and metformin for life, and antidepressants for life, and Viagra for life. And all of these things have risks, which they have discovered through focus groups are totally ignored by the people watching the television commercial. Where the word tuberculosis comes by in the Humira ad, they pay a little bit of attention, but beyond that, we're not thinking about it. We really need to look at the causes of the autoimmune conditions and other things. We also need strong interventions, and let me pick on the Women's Health Initiative just briefly. I personally think it was a very good trial, but because it was such an ambitiously huge trial with tens of thousands of participants, the intervention couldn't be very strong. You couldn't hold everybody's hand as they were making their diet changes and really encourage them to make a big change. So we need adequately powered trials, but the interventions have to be strong. So don't cut your fat intake a little bit. Let's get the animal products out of your diet. Let's keep the oils really low. Let's have healthy foods and see what we can do with that. And we need good control groups. The Women's Healthy Eating and Living study, which I think was an excellent study, but it coordinated out of San Diego, taught us a lesson. Women with breast cancer were brought in and randomized, some of whom were asked to eat a lot of vegetables and fruits and vegetable juices, 8 servings a day, and the control group was asked to have 5 a day, because that's what you're supposed to eat. Well, wait a minute. You've now got a control group of women diagnosed with breast cancer who don't want to die. And you've told them to have 5 servings of vegetables and fruits a day, and they know that you're testing a hypothesis as to what this is going to do. You don't have a control group, you've got 2 intervention groups, both of whom are totally motivated. So it was a good trial, but we learned a lesson, that we've got to have an adequate basis for comparison. Now, there are ethical issues in doing that, obviously, but they have to be tackled. We need to reach into communities, not just our research center, and we need to deal with children. In Washington, D.C., where I live, colorectal cancer incidence is 3-fold higher in the poorest parts of Washington compared to the wealthiest parts of Washington. Diabetes mortality is 6 or 7 or 8 times higher in the poorest parts of the city. We need to do interventions that work where people are. I don't need to know that a vegan diet is going to reduce cholesterol. I need to know that it will do it in the community, in the clinic. So we need to roll up our sleeves to do that kind of research. We need to study humans. We do not need another dog trial of heart failure. I don't want another mouse model of Alzheimer's to show me the drugs aren't working. We need to focus on human beings, and that means human populations, it means human genetics, it means human behavior, and it's challenging, but if I'm going to use an animal model, it's tantalizing to do it because you can control all kinds of things, but you are then forced to try to extrapolate what does this actually mean in the context of an immune system that is not human, and so forth. Okay, and finally, we need to be aware of industry. We saw this tragically 8 weeks ago when the Annals of Internal Medicine published articles saying, and a press release, saying that there's no need to cut back on processed meat or red meat for heart health. And it was only after the fact that it was revealed that although the authors declared no conflict of interest, that the Texas A&M AgriLife, which has conducted almost $5 million of beef research this year alone, had funded the lead author on this, gave him a job, which he had accepted before the articles came out, and funded them to do a new trial on saturated fat, which is now underway. And the same author published an article 3 years ago, published by the food industry, saying that sugar won't hurt you. And I might mention that it was edited by the same editor and published by the very same journal. And it's tantalizing to have clickbait that bacon is good for you. That's a story that people are going to cover, but it's a lie and it's corruption, and we've got to do what we can to oppose this kind of thing. It's challenging in this world where honesty is now optional, but we really do need to make sure that science has integrity. That's a tall order, but that's where we're going to get, because otherwise we get this kind of stuff. Eat butter. All right. Forgive me for taking such a 30,000 feet view of some pretty tough topics, but I hope this has been a useful beginning to our discussion. Thank you again, Mike, for letting me share this time.
Thank you for this really comprehensive review of a vast amount of literature on diet and health. I'm not going to repeat what you have already said. I think the research directions that you have pointed out are really important. I think those are important areas we should pursue. I just want to add a few points. The first one is that we should put more emphasis on diet quality. No matter what kind of study we do, what kind of diet we prescribe for our patients. And the quality of the diet is not easy to define because there's so many parameters that can be used to define quality of diet. We have used various indices to define diet quality. For example, the Healthy Eating Index, which includes 10 components that can rank people, individuals' diet quality from 0 to 10. So on average, the American diet quality, the Healthy Eating Index is about 5, so it's very low. And if you give a grade, the diet quality report card for the U.S. population is probably a C or D. So that's one way to characterize diet quality at population level. You can also do this at individual level. We have looked at the quality of different components of diet. Of course, the quality of the dietary fat is very important. We know that not all fats are created equal. There are good fats and bad fats. For cardiovascular disease prevention, it seems that the type of fat or the quantity of fat is more important than the total amount of fat. We can also say the same thing for dietary carbohydrates and protein. Dietary carbohydrates, again, like dietary fats, are very heterogeneous, and we have a lot of refined carbohydrates, high glycemic index carbohydrates in our diet, and the consumption of high quality carbohydrates such as whole grains and legumes is very low in the U.S. population, well below the recommended level by the USDA dietary guidelines. In terms of dietary protein, we have already talked about plant-based protein versus animal protein. I think the evidence is very clear that higher consumption of plant-based protein instead of animal protein has beneficial effects on a wide range of health outcomes. So again, when we talk about low-fat diet, high-fat diet, low-carbohydrate diet, and or high-carbohydrate diet, I think this kind of terminology is not very meaningful unless we specify the quality or the sources of dietary fat, carbohydrate, or protein. We will have a paper coming out in JAMA Internal Medicine soon, looking at different versions of low-carbohydrate diet, different versions of low-fat diet. What we found is that you can have perfectly healthy low-fat diet or perfectly healthy low-carbohydrate diet, but you can also have very bad low-fat diet and very bad low-carbohydrate diet, depending on where you get your food sources of fat, or carbohydrate, or protein. So again, I think the traditional view of low-fat versus low-carb is not very meaningful unless we specify the quality or the food sources of those macronutrients. The same concept applies to plant-based diets, because we have been talking about plant-based diet, and there is a misperception that plant-based diets are equal to vegetarian diets or vegan diets. But I think if you look at the literature, the definition of plant-based diet is much broader than just a vegetarian diet or vegan diet, because many of the plant-based dietary patterns tested in clinical trials or analyzed in observational studies do include some small amount of animal products, including poultry, fish, and a small amount of red meat. So the range of plant-based diets is quite large. And also, we can have healthful plant-based diets if most of the plant-based foods come from minimally processed plant foods, such as fruits and vegetables, whole grains, nuts, and legumes. But you can also have very bad plant-based diets if most of your plant-based foods come from veggie pizza, Coca-Cola, and those kind of things. So in our previous studies, we classified people into different plant-based dietary patterns, so healthful plant-based patterns versus unhealthful plant-based patterns, and people who consume healthful plant-based patterns have much lower risk of type 2 diabetes and cardiovascular disease, and people who consume high amount of unhealthful plant-based foods such as refined carbohydrates, added sugar, and so on and so forth. They actually have increased risk of developing type 2 diabetes, and their risk of developing metabolic disease is actually higher than people who consume relatively high amount of animal products. So again, I think we need to be very careful and also very sophisticated when we talk about different dietary patterns, and really have to pay attention to the quality of the macronutrients, quality of foods, and the quality of dietary patterns.
So thank you. a lot of what I was going to say has a lot of correlation with what Dr. Hugh just said. In the lifestyle medicine world, we talk a lot about whole food, plant-based, and actually the mantra that I like the most, that comes up a lot in the lifestyle medicine world, is Michael Pollan's "Eat food, not too much, mostly plants." Again, it feels like the conversation ends up focusing on this mostly plants piece. And right now, one of my strengths is I'm primarily a clinician. I see patients a high percentage of my life. And I can tell you that for a patient, they get the difference between an animal product and a plant-based product. It's harder for them to get the difference between a processed food and an unprocessed food. And as a clinician, it's really hard for me to help them understand the differences. I think research into helping us really help a patient understand this is what a high quality food is and this is what a poor quality food is, because patients don't know. And one of the points that Dr. Barnard made that I think is incredibly important, there's a lot of people out there that actually don't want them to know. They want this disinformation campaign that happens out there, because the more confused a person is, the more likely they are to buy some of these processed foods. I also think that we don't spend enough time talking about that second part, not too much. I actually think it does matter, and it certainly matters as I interact with my patients. And if you look at some of the research coming out of Walter Longo's shop and some of the other people that are looking at how you eat, it's actually very important. And we don't spend enough time talking about that in the lifestyle medicine world too. So those are my big things. I put a little graph there from the recent study by Hall looking at ultra-processed food, where he saw that there was a 500 calorie excess intake with ultra-processed food versus this was a very small feeding study, but it would be nice to look at some of that in the real world. So then if you just advance. So the final thing that I wanted to just briefly bring up, because it wasn't in Neal's slides, is the importance of nutrition as far as renal disease. Again, part of what I'm trying to do is look at the economic basis for lifestyle medicine. I think we have a lot of data around science. We have a lot of data around it being the right thing to do, but we need more data around the economic components of lifestyle medicine. And if you look at the top cost drivers, the patients, your high utilizer patients, a large percentage of them are people who have kidney disease. And it feels to me like we've got some data coming out that's showing that renal disease is dramatically affected by diet. We haven't really spent a lot of time talking about that, but I think that's an important area, not the least because it's an important area from a cost perspective. So those are sort of the points I wanted to bring out.
Well, thank you. For those of you who I've not met, I'm Kim Williams from Rush University, and I really have enjoyed the beginning of this, and I'm really thrilled to be here because this is an opportunity to try to coalesce some of the ideas that I think are going to help us. I'd like to sort of react in sort of more of a 35,000-foot view, and then drill down very specifically on the population that I serve. First at the University of Chicago on the south side of Chicago, and then in Detroit, and now on the west side of Chicago again. But the 35,000-foot view, there are recent publications, and a lot of this was brought out at the last heart meetings, that cardiovascular disease globally is increasing, and it's been the #1 killer of Americans, and it's on the rise. And sure that the recent publication says it's, opioid and addiction and that sort of thing is taking over, but heart disease is still the #1 killer of Americans. And it's interesting that if you look globally, the low and middle income countries Heart disease is number one, no question about it, and that is something that's happened over the last couple of decades, taking over from infectious disease and everything and the like. But there's only one high-income country on the planet where heart disease is still number one, and that's the United States of America. And it's because of our lifestyle, so I'm so glad that you're here. One of the things that I've happened to be blessed to do in my career was I was a Medicare advisor for 4 years. Got to understand what they're all about, trying to take this unhealthy population bent on hurting themselves and yet not dying. Okay, so if you die, you're helping Medicare. If you don't die and you're sick, you're killing their budget. And sure enough, they're very dedicated and they're running out of money. And so the Medicare trustees announced that in 2026, the Medicare system will be bankrupt. And at the last AMA, we sort of were talking about what does that mean? They're anticipating that would be a 30% cut to physician fees and hospital payments in order to try to survive for another who knows. And so what are we going to do about that? Now, if I take those sort of very large principles and then drill down to the people whom I serve, the African American population where I grew up and who I'm serving all the time, you know, we have a problem. We are the problem. That is that almost 50% of all African Americans in adulthood have some form of cardiovascular disease, hypertension, stroke, heart failure, coronary heart disease. And, you know, I may have trouble getting everyone interested in that little fact until I mention that we're talking about a historically, socioeconomically depressed set of people. And if they do not die from their disease, who's paying for all of their care? It's pretty much everyone in this room, right? And so if you look at some of the numbers, they're outlandish. That is, if African American has a stroke, the stroke care is like $10,000, just $25,000 a year from Medicare. And I'm so glad you mentioned kidney disease, because that's uniquely problematic in the African American population. It's diet and the ApoL1 gene, okay? And for a dialysis patient, it's $90,000. Up from $87,500 to $90,000 per year that Medicare pays, because when you have that stroke and you have the chronic kidney disease, you're disabled. So it's not just 65 and over that Medicare covers. It's 65 and over plus the disabled population. And so we really don't have as much in the way of African American intervention trials as we would like. We have Dr. Fraser's Adventist Health Studies, where he's carefully looked at what's happened in what happens in the African American population if you fix the diet. And the dramatic, if you know, don't want to misquote it, but my recollection is you take every single risk factor and they drop by 50% if you just fix the diet. The Regards trial, University of Alabama, Birmingham, really called out what they call it the Southern diet, and I guess in the stroke belt it does apply to other people other than African Americans, but it's that African American pattern of soul food, high salt, high fat, high sugar in the diet, organ meats and all the grains, that sort of thing. And this is producing a lot of premature cardiovascular disease and a lot of premature death. And so yes, we are thinking that we need more trials. You know, I recently participated in producing or helping to write the prevention guidelines for the American College of Cardiology, American Heart Association. I know Eduardo Sanchez, maybe he stepped out so I could speak freely. Oh no, there he is. Okay, so I have to hold what I say. Just kidding. Well, yeah, the first rule of Fight Club, quoting Brad Pitt here, is you don't talk about Fight Club, right? The idea is that when you're in that room trying to produce guidelines, you're held to an incredibly high standard. Drop your ego at the door. And I come out a little bruised talking about plant-based nutrition for everything that Neal said. That where he said we need a real trial in this area, I give them observational stuff done by many people in this room, and they say, yeah, thank you very much, that's observational, it doesn't count. And so, yes, we do have guidelines, and we don't have level 1 recommendations for the things that we all believe in that could help this population. And that's a gap that really needs to be filled. I am fortunate to be at Rush University, where Martha Claire Morris, who was mentioned, doing her interventions for the MIND trial. I'd like to extend those for heart trials, and she's convinced me that I'll never get any funding unless we do an interventions, and have some preliminary data. So we did one this year over Lent in an African American church, and we presented at the American Heart Association a couple weeks ago. But the things that really stick out is how quickly, if you do a plant-based intervention in a high-risk population, you can change those risk factors. Everything we wanted to accomplish actually happened. Probably the biggest ones that hopefully we'll be publishing soon were the 43% drop in insulin levels and TMAO, trimethylamine N-oxide. But everything improved. And so we can do interventions, and that, I think, is where we need to go. And I'm hoping that this meeting will culminate in not just a white paper, but a way forward for everyone to try to take the most at-risk population. And notice I didn't say anything about Hispanics, who have their own, the big issue of Hispanic and cardiovascular disease is that they have more risk factors and longer lives. That's not helping. Okay, dying early or living long sick, neither of those are what we really aspire to. So I'm hoping that the real outcome of this is that we're going to have way forward for intervention trials that will change our guidelines and change the cardiovascular health of not just the population, but the providers as well. Because like I always say, the leading cause of death of cardiologists is still heart disease. And that really is something that we need to fix. Thank you.
Thanks, Kim. For the panel, I'm going to open it up here in a minute, but I will tell you that I'm going to put on my health plan hat. Many people know me. I never use the word payer. My 18-year-old son, who's already bankrupt, he's in college, but he's the only payer, really, because it's coming out of his future. Health insurance plans are middlemen at best to get between what doctors and patients would like to do, perhaps more often than they can. But what we're looking at is exactly what you brought up, Wayne, is the gold mine, both to solve the Medicare trust fund problem and to solve the near-term MER, the proverbial thing, is to get the people who are on that slippery slope to chronic renal failure and on those drugs, off those drugs, and to basically get them off. So finding these pockets of highest cost, highest disease burden that is amenable, and Kim, you're saying that it's there. It's there. So getting to the practical trials in the right communities with the 5 or 6 diseases in the states that you talked about, Neal, I think is a great roadmap for the nutrition research across the spectrum. So questions or comments from colleagues for the panel? Go ahead.
Thank you very much for your comments. This is great.
Can you use the mic when there's there? You just need to tap it to turn it on. Because we're recording and it all goes to it. There's a little button that says it should just go on. Is it green?
Okay. I think we got it. I think we got it now. Thank you. Well, thank you. This is a great way for, I think, us to kick things off. Right before we started, I was actually having a conversation with Eddie about medical education and the importance of socializing this early. So pharma has done this better than we have. Pharma gets involved with our residents and our fellows and indoctrinates them into what they should be prescribing, what their patterns should look like. But there's very little in the curriculum for medical school training or residency training on how to incorporate this. And there are a lot of things working against that because there's little time for physicians in their busy practices to counsel patients on some of these issues, as you know. There's our younger physicians who come out with a lot of medical school debt are enthralled by procedures that are higher paying. This is something that we're working to shift that balance a little bit here as well as in other settings. But there are a lot of things working against that, and physicians don't feel equipped and knowledgeable about some of these topics. So I just wondered if the panel could comment on how we can get this more ingrained and socialized very early so it's not something that has to be learned later or added on, but it's part of mainstream practice. So your thoughts?
I'll just jump in. I'm also chair of the American Board of Lifestyle Medicine, which is a certification body for lifestyle medicine, and we are actively trying to support getting this into residency education. Getting people. We now have over 1,000 people certified in lifestyle medicine. It's just been around for 2 years, so there's definitely movement. There's a question bank that's being developed, which will be available for medical schools to incorporate these kind of questions into their standardized exams. So there's definitely movement going on, but as you pointed out, there's a lot more work that needs to be done, and you know, at some point the nutrition course needs to be just as many hours as the pharmacology course.
I think that's really important, and I would add that having it, if you could ever get it into medical education in the first place, that would be miraculous. But that alone is not sufficient, because how many of us do really well with medical practice if we're only relying on what we learned up to getting through our training? Science moves on. So my point is that nutrition also has to be part of continuing medical education. And we're fighting a battle right now in Washington, D.C., where there's a bill in the city council that we proposed, that we introduced, that would require 1 hour a year of nutrition education for physicians and nurses. And you wouldn't believe how much opposition we're getting from physicians and nurses saying, don't tell us what to do. But anyway, I would value anyone's support in doing that. By the way, I was remiss in, I want to just recognize Dr. Katz just really quickly, if you don't mind it. When I was talking about industry's influence, nobody has really done a better job than the True Health Institute for getting the word out about this. So I just wanted to recognize Dr. Katz for his work, and also for encouraging medical students to learn about this and get inspired and to make it part of their practice.
Well, our experience in terms of nutrition education in medical curriculum, I think is the same as others. We used to have a nutrition course at Harvard Medical School, but it was cut several years ago, very unfortunate, because the rationale was that there was no nutrition question in the board exam, right?
There you go, circular logic. Yeah.
And but there is very high demand among the medical students for nutrition education, even for learning cooking skills. So just last year, Chris Duggan, who is now the editor-in-chief of American Journal of Clinical Nutrition, restarted the nutrition course for medical students. It's not a required course, it's a selective course, but there is a very large enthusiasm among the medical students to learn nutrition and also learn cooking skills. So we are now developing teaching kitchens for not just for medical students, but also for residents and the doctors who can learn how to incorporate their nutrition knowledges into their practice.
As a teaser, you will be seeing the very slick teaching kitchen at Phipps Conservatory, the visionaries that built that. You'll see that this evening. Indulge me here. We're going to try to stay on time, so I'll take one more question, then we're around for the whole 2 days to talk to anybody. Victoria.
Mine is actually a comment. Good morning. Wonderful beginning. I'm Victoria Mazes from the University of Arizona Center for Integrative Medicine. And I wanted to respond that the University of Arizona has developed a 200-hour curriculum, about 30 hours are nutrition. And we have this at 88 residencies around the United States: family medicine, pediatrics, internal medicine, preventive medicine. So we do have a standardized curriculum. It is being incorporated. The residents are eager to learn it. In fact, they go specifically when they interview to the places that offer this curriculum as part of their training. And we've done many other nutrition education interventions. I think that there's enormous demand, especially in the new generation who are coming into medicine.